All right, welcome back to The Explainer. Today, we are dropping straight into the trauma bay, a place where success isn't just about making a quick diagnosis, it's about executing exact mathematical matrices of resuscitation. We're going to hyper-focus on the granular physiological details and those really complex decision boundaries where even the most subtle variables completely shift your patient management.
Here is our clinical triage board for today. We're going to rapidly process through 4 main modules. Module 1, Shock Hydrodynamics. Module 2, Thermal Crises. Module 3, Burn Physics. And we'll wrap up with Module 4, Disruptive Emergency Traps. Let's get right into it.
Starting with Module 1, Shock Hydrodynamics, we're looking at the invisible architecture of systemic collapse, specifically vascular resistance versus wedge pressures.
Okay, so to isolate the exact cause of profound hypotension, you really have to lean on a strict hemodynamic matrix. You're evaluating this using your pulmonary capillary wedge pressure, or PCW, and mixed venous oxygen saturation, your SVO2. Let's break this down. Cardiogenic shock drives wedge pressures high while cardiac output totally drops. Now, in both cardiogenic and hypovolemic shock, you're going to see a low SVO2. Why? Because the tissues are absolutely starving, extracting as much oxygen as they possibly can from that sluggish blood flow. But look at the mixed shock execution boundary. In early septic or distributive shock, you actually see a high SVO2. The cells are literally unable to extract oxygen despite a hyperdynamic cardiac output. And then, of course, you have neurogenic shock, which just completely disrupts sympathetic outflow, crashing your systemic vascular resistance and presenting with a very weird bradycardia instead of the tachycardia you might expect.
Think about distributive shock in action. It is a profound mechanical failure. Take anaphylaxis. Massive IgE-mediated histamine release completely tanks your systemic vascular resistance. Your cardiac output initially spikes to try and compensate, but if left untreated, total decompensation is right around the corner. The immediate mandate here isn't just pushing epinephrine to clamp down those arteries. You need aggressive isotonic crystalloids to force that preload back up and restore circulating volume.
Which brings us to your first major clinical variance box, the vasopressor trap. Look, if a patient is hypovolemic, do not, I repeat, do not reach for pure vasopressors before you've given adequate fluid expansion. Pushing total peripheral resistance up while the tank is totally empty will, sure, technically make your blood pressure numbers look better on the monitor, but it absolutely decreases actual blood flow to the tissues. You trigger autoregulation, and you end up causing catastrophic ischemic damage, like melting their digits off. You have to fill the tank first.
Moving on to Module 2, Thermal Crises. Let's see how environmental forces dictate your core temperature forks.
Distinguishing the root mechanical failures here is absolutely vital. Severe hypothermia makes the myocardium incredibly irritable. We're talking deadly J-wave or Osborne wave arrhythmias and severe bradycardia. You actually have to handle these patients physically gently or you'll throw them straight into VFib. On the flip side, you have severe hyperthermia. Heat stroke, right? When the core temp exceeds 40 degrees Celsius, it is essentially melting the central nervous system and driving multi-organ failure. The mandate there is immediate, rapid evaporative spray cooling or ice water immersion.
Now I want you to focus on this number, 28 degrees Celsius. This is your absolute physiological red line for severe hypothermia. When a patient drops below 28 degrees, they're comatose. You have to abandon the simple warm blankets. You shift immediately to active internal core rewarming, warmed pleural or peritoneal lavage, or ECMO. And remember the strict defibrillation rule. An unstable, severely hypothermic heart will almost never respond to electrical shocks or antiarrhythmics until you drive that core temperature back above 30 degrees Celsius.
Then we have 32 degrees Celsius. This is your legal and physiological boundary. Yes, a patient stops shivering at this temp as they cool down. But more importantly for resuscitation, you cannot pronounce a patient dead until their core temperature crosses back above this line. The old trauma bay adage is 100% true. A patient is not dead until they are warm and dead.
Let's look at another thermal variance box. This isolates a hidden, highly lethal hospital trap. An immediate, massive temperature spike right after receiving anesthesia drugs like halothane or succinylcholine, that is not a standard post-op fever. That is malignant hyperthermia. You need to immediately assess for muscle rigidity, check for metabolic acidosis, and slam them with dantrolene while initiating active cooling.
Advancing to Module 3 now, Burn Physics in the Parkland Volume Matrix.
Thermal skin destruction essentially creates a massive systemic capillary leak. It drives huge fluid shifts from the intravascular compartment straight into the interstitial spaces, causing devastating hypovolemic burn shock. To combat this, you have to calculate a strict volume matrix using the Parkland formula: 4 multiplied by the patient's weight in kilos, multiplied by the percentage of body surface area burned, and remember to calculate that area using the rule of nines. But here's a huge error mitigation point: strictly exclude first-degree superficial burns from your math. Including sunburns in this formula is a classic trap that will lead to massive fluid overload.
Okay, so you've done the math, but that's only step 1. Your choice architecture here is forced by a very strict timing matrix. You have to deliver exactly 50% of that massive fluid load within a compressed 8-hour window. And here is the real kicker that catches people out. That 8-hour clock starts from the exact time of the initial burn injury, not the time they rolled through the ED doors. So, if a 70-kilo patient with 40% burns arrives 3 hours after the explosion, you are forced to cram that entire first half of the fluid volume into a compressed 5-hour delivery window.
So how do you track success? A target of 0.5 to 1.0 cc per kilogram per hour is your objective metric. You titrate that fluid torrent to maintain this strict urine output. It is the single most reliable indicator that your fluid resuscitation is actually perfusing the end organs.
Here is your burn variance box, the asphyxiation trap. This is the invisible killer that rides shotgun with severe burns, especially in closed-space fire exposures. You've got to suspect carbon monoxide poisoning. The trap here is that your pulse oximetry might read a totally normal oxygen saturation. It's lying to you. The patient is comatose with cherry red flushed skin and critically elevated carboxyhemoglobin. The immediate treatment matrix forces a 100% oxygen override, or getting them to hyperbaric oxygen if it's severe.
All right, finally, Module 4, Clinical Reconciliation. It's time to test your ability to synthesize these red lines to survive disruptive emergency traps.
Imagine this scenario. You've got a trauma patient crashing with profound circulatory collapse. They are completely refractory to both massive fluid loading and standard vasopressors. What do? You must isolate occult adrenal crisis. This is an acute failure to meet the massive physiological demand for endogenous cortisol during a major stressor. To restore systemic vascular resistance, you have to recognize the trap instantly and push intravenous corticosteroids. Now, for the ultimate physiological test, an integrative scenario. A polytrauma patient rolls in. They have severe full-thickness burns, massive hemorrhage, and a core hypothermic temperature of 27 degrees Celsius. They enter pulseless electrical activity. How do you sequence the Parkland matrix and hemorrhagic resuscitation on a heart that is far too irritable to shock and won't successfully restart until the core temperature climbs past 30 degrees?
The execution here is a beautifully delicate sequence. You secure the airway. You aggressively pushed warmed IV crystalloids and blood products. This does 3 things simultaneously. It restores the intravascular volume lost to hemorrhage, it initiates the massive fluid replacement needed for the burn capillary leak, and it provides active internal rewarming to drive that core temperature up. And crucially, you intentionally withhold pure vasopressors that would only accelerate the ischemic death spiral in an already empty freezing vascular system.
Understanding these extremely precise boundaries is exactly what separates standard care from true, life-saving execution. A single missed variable, timing the burn fluids wrong or trying to shock a 27-degree heart, results in total failure. So, as we wrap up this explainer, ask yourself, are your mental matrices truly robust enough to navigate these clinical red lines when the clock is ticking and the chaos hits? Think on that, keep refining those algorithms, and I'll catch you in the next one.